Bradycardia preceding recurrent cardiac arrest in the setting of an anomalous origin of the left main coronary artery. Introduction. Anomalous origin of a coronary artery from the opposite sinus of Valsalva is an uncommon congenital defect that is encountered in only 1% of those undergoing cardiac catheterization. Otherwise, it is diagnosed post-mortem. The risk of sudden cardiac death is much higher than in patients with anomalous left main coronary artery than those with anomalous right coronary artery. Patients typically present with sudden cardiac death, syncope, or chest pain. There are 4 courses anomalous origin of the left main coronary artery may take when arising from the right coronary cusp, which include anterior, septal, interarterial, or retroaortic. Case presentation. We present a case of a 64-year-old male who came to the hospital for gradually worsening shortness of breath for the past several days. His past medical history included hypertension, non-insulin-dependent diabetes, and dyslipidemia. On initial physical exam, his vitals were normal, and physical exam was pertinent only for changes of volume overload. Initial EKG was normal sinus rhythm with first-degree AV block without ST changes, and echocardiogram demonstrated normal LVF at 65% with no valvular issues or structural heart changes. He had a complicated hospital course lasting almost 100 days. On day 24 of hospitalization, a code blue was called and ACLS protocol was started. Prior to the code, the patient was bradycardic with heart rate in the 30s, leading into an asystole arrest. Return of spontaneous circulation, or ROSC, was achieved in 5 minutes. The troponin at the time was remarkably normal, and EKG was similar to the one on admission. On day 28, he underwent another cardiac arrest, and this time was noted to be in pulseless electrical activity, or in a PA arrest. ACLS protocol again started, and ROSC achieved in 5 minutes. EKG again showed no changes from prior EKGs, and troponin again normal. On day 71, a third code blue was called and ROSC achieved in 4 minutes. Tele again showed a bradycardia into a PA arrest, and EKG again was similar with normal sinus rhythm and no changes from prior. Troponin again normal, and repeat echocardiogram obtained at this time showed similar results as the one obtained on admission. On day 76, patient underwent a left heart catheterization and was found to have non-obstructive coronary artery disease. An incidental finding was noted of anomalous origin of the left main coronary artery from the right coronary cusp. From day 77 to 89, the patient was seen by cardiothoracic surgery and EP teams who recommended that the patient follow up as an outpatient given his deconditioned status. On day 90, patient had an additional cardiac arrest and ACL's protocol was started with ROSC achieved in less than 1 minute. Tele again showed bradycardia into a PA arrest. He was discharged around 1 week later and recommended to follow up with cardiology and cardiothoracic teams closely. In summary, the patient underwent 4 cardiac arrests during his hospitalization that followed a similar pattern, with bradycardia preceding either PA or asystole arrest. His arrests were attributed to probable transient ischemia-induced cardiac arrest in the setting of anomalous origin of the left main coronary artery from the right coronary cusp. Unfortunately, no intervention was done inpatient given the deconditioned nature of the patient. In figures 1 and 2, we see 3D reconstructed images of coronary CTA showing anomalous origin of the left main with high takeoff arising approximately 5 millimeters above the sinotabular junction above the level of the right coronary cusp. Discussion. Several mechanisms for cardiac injuries in the setting of anomalous left main coronary artery have been described. When the anomalous artery courses interarterial or between the aorta and pulmonary artery, the increase in the pressure between the two vessels occurring during the exertion could cause a compression of the vessel, which could then cause myocardial ischemia. If the initial pathway is instead intramural, that segment of the coronary artery may be compressed and deformed within the aortic wall during periods of hypertension. The normal coronary artery arises at a perpendicular angle to the aorta, in contrast to the anomalous coronary artery arising from the opposite sinus, which comes off an acute angle and bends over itself to reach its normal supply territory. The magnitude of ischemic risk is then related to this degree of angulation. There are several reasons why the patient might have had bradycardia leading into PA or asystole cardiac arrest. With anomalous coronary arteries, there could be episodic global left ventricular ischemia, which causes low cardiac output with bradycardia leading up to asystole. Another reason may be that due to the sharing of the cusp by the RCA and the left main coronary arteries, there is decreased blood to the RCA, which is the main supplier to the AV and SA nodes. Surgical repair or percutaneous intervention of coronary arteries with anomalous origin have generally been the standard of practice. Surgical intervention is preferred in young patients, and percutaneous procedures can be performed in older adults who may not be surgical candidates, as in our patient. Young patients diagnosed incidentally should be advised to avoid heavy exercise. Our presentation of our patient is of recurrent bradycardia preceding his cardiac arrest is not commonly described. It is possible that bradycardia is also present in other cases that is present with sudden cardiac death, but that information is not actively available as those patients were not being monitored on cardiac telemetry. Thank you.